Hello and welcome to Module 4 of the Global Health Starter Kit, Social Determinants and Risks, co-authored with Jennifer Casper and Karen Sakul Gutierrez. This module introduces concepts of social and societal determinants of health, vulnerable populations, the bottom billion, and the sociocultural and biomedical models for health. While there are numerous resources and references available about these topics, for the purpose of this module, we have curated for you a small sample of high-quality resources to support your learning outcomes. We encourage you to explore the literature further beyond what is contained in this module. This module is related to the competencies shown here from the Global Oral Health Competency Matrix. While these competencies cannot be met through a single teaching module, this module is working toward competency-based best practices in global health for dental education. For Module 4, we aim to meet the following learning objectives. Define the social determinants of health. Describe the social gradient in health. Explain the concept of the bottom billion, their indicators and characteristics. Define the biomedical model and sociocultural model for health, and discuss the advantages and disadvantages of each. Let's begin with a fairly straightforward question. What causes a cavity? You probably have a variety of ways that you could answer this. So let's review the classic formula for a cavity. Bacteria plus sugar plus a susceptible tooth, you remember the fourth one? Plus time, and ouch, you get a cavity. This formula sounds familiar, right? In the classic definition, a susceptible tooth is defined as a tooth without any protective factors in place, such as community water fluoridation or sealants, for example. Other examples of a susceptible tooth could be a tooth with a poorly contoured restoration or open margins, or unusual anatomical features that can become plaque traps. In this module, we are going to expand this definition of susceptible tooth and work to more thoroughly answer the question, what is a susceptible tooth? There are many other determinants and risk factors for cavities well beyond what's captured in this formula. And today, we know factors that make a tooth susceptible extend well beyond just the physiology of the tooth and the immediate oral environment. We'll spend the rest of this module identifying all the aspects in a person's life that make them and their teeth more susceptible to cavities and health problems more broadly. So let's start with a warm-up. Now, you might recall that we met Dr. Tooth, the dentist, in Module 2, and we explored all the components of a health system needed for Dr. Tooth to be able to practice dentistry and treat the patients who need care. So as a refresher, do you remember the 6 components of a health system? Leadership and governance, so things like a license to practice and a scope of practice. Health information, so information about disease burden, health needs, patient-provider ratios, etc. Health financing and payment, so funding for provider training, funding for healthcare services, insurance, or a way to pay for care, etc. The fourth one, healthcare workforce, so adequately trained staff. Fifth, supplies, equipment, and technology. And finally, service delivery, which includes access to both quality of care and ethical care. So for today's warm-up, we're going to meet a person from the community. Meet Joe. Joe can be anyone, any gender, any age, any income level, living anywhere in the world. So really expand your ideas. Who is Joe? Poor Joe. Joe has a toothache, a bad one. So what should Joe do? So like most, you're probably thinking, go to the dentist. And yes, Joe needs to see a dentist. Let's pretend Dr. Tooth from Module 2 could be his dentist. But there are many things that need to happen way before Joe can sit down in Dr. Tooth's dental chair. So imagine this is a timeline beneath Joe here. And I put Dr. Tooth, Joe's dentist, at the end of this imaginary timeline. What needs to happen for Joe to see Dr. Tooth? You might be thinking he needs to get there or have a way to pay for it. Or you might be thinking Joe needs to know it's important to see a dentist for a toothache. If that's what you're thinking, you're on the right track. First, before anything else can happen, Joe needs to decide to go to the dentist. And it's not even that simple. How does Joe make this decision? What factors influence this decision? This is about deciding to seek appropriate care. And things that influence that are Joe's culture and cultural beliefs, Joe's health literacy and oral health literacy, Joe's ability to take time off to go to the dentist. So maybe Joe knows he needs to go and wants to go, but has decided not to because he can't afford to miss work. Or maybe he doesn't recognize that when you have a toothache, the dentist is who you should go see. Perhaps Joe's facing other pressing priorities for his own health or for the health of a family member and has to put his tooth second to that. So there are a lot of things that impact Joe's actual decision to go. So let's say Joe's overcome these potential challenges and has successfully made the decision to go. Good job, Joe. So now what? Next, Joe needs to be able to reach an appropriate facility, like Dr. Tooth's office. So what impacts Joe's ability to do this? So think about, what if Joe lives in a really rural area and there isn't a facility where he lives or anywhere nearby? Or perhaps there aren't adequate roads to get Joe to a facility. Maybe he doesn't have any access to transportation. He can't afford a car, he can't afford a bus fare, or maybe there's not a public transportation option. Finances could be impeding his ability to travel to a clinic, or perhaps there's bad weather and the roads are flooded, or maybe it's mud season, or if they live in an Arctic region, sometimes people have to wait until the spring thaw to use the roads once again. So there can be a lot of barriers in place. So even after Joe's decided to go, getting there can be just as much of a challenge. Okay, so let's say Joe overcame all the barriers in place that affect making the decision to seek care. Then Joe overcame all the challenges in reaching a place to get treatment. So now, here we are at the dental office. There are still many factors that influence Joe's ability to receive care. So can you think of some? What if he gets there and there's no provider there? Or the provider's not trained for what Joe needs? Or what if there's a language barrier? What if Joe doesn't speak the same language as the health provider and can't express what's going on or can't understand what he's supposed to do? Or perhaps it's been a tough year for the clinic and they're understaffed or undersupplied, or they don't have the necessary equipment to care for Joe. Or what if Joe gets there and once he realizes what he needs, he simply can't afford the care? So again, this is a third delay that can occur once someone gets to a facility, but they actually can't receive the care they need. So these three categories of barriers that we've just talked about are known as the 3 delays to receiving appropriate quality care Joe needs to get well. Delay number 1, deciding to seek appropriate care. Delay number 2, reaching an appropriate facility. And delay number 3, receiving appropriate quality care. The 3 delays were originally described for pregnant women getting ready to give birth and examining reasons for high maternal mortality in Haiti. Even though they are actually not about oral health, the themes and determinants described in the 3 delays model certainly apply to us as dental providers and our patients. I encourage you to learn more about the 3 delays on your own after this module. What I find so compelling about the 3 delays is they describe barriers to care that are out of Joe's control, barriers that have nothing to do with Joe's own behaviors, really. Many are just plain due to bad luck or the circumstances Joe was born into or lives in. For example, did you know in the United States, your zip code is a determinant of your life expectancy? In other words, we are likely to live longer or die at an earlier age depending on which county we were born in. It doesn't really seem fair, does it? As we are learning from Joe, it turns out that individuals, children, and families can have dramatically different health outcomes, such as life expectancies, depending on where they live in the world and where they are born, like the US zip code example. Children born in Japan might live to be 84 years or older, where children born in Sierra Leone have a life expectancy of only 46 years. These drastic differences are attributed to things like where a person lives, their social, physical, employment, and economic circumstances, and their access to basic needs and services. These factors are known as the social determinants of health. These determinants affect oral health as well. Many of the obstacles to oral care Joe experiences in our previous warm-up exercise are linked either directly or indirectly to the social determinants of health. One of the strongest predictors of health outcomes, including oral health outcomes, is poverty. As a person's income rises, oral disease burden falls. This is known as the social gradient in health. Now, this graphic here is a simple visual to demonstrate the social gradient. It should be noted that this gradient exists on an individual level but may not hold true at the community or population level. So, for example, some low-income countries have a lower oral disease burden on average than some middle-income countries. This may be in part because middle-income countries have the largest proportion of people living in extreme poverty today. Studies have also shown a negative relationship between income and oral health due to a number of factors, such as geography and access to junk food. So the details and nuance of this relationship are out of the scope of this module. But the key message here for this slide is that one of the strongest predictors of poor oral health outcomes in general is poverty. In September 2000, world leaders convened for the United Nations Millennium Summit at the UN headquarters in New York City. The resulting document, the Millennium Declaration, resolved that leading into the new millennium, a major challenge for global development was the needs of developing countries and emerging economies. It declared that we have a collective responsibility to uphold human dignity, equity, and equality. The declaration set forth concrete, measurable objectives for achieving those outcomes, with a strong focus on reducing poverty. These became known as the Millennium Development Goals, the MDGs. The MDGs led to dramatic improvements in health around the world, and these goals are discussed in more detail in Module 2. As the world began to make significant progress in achieving the MDGs, a problematic observation was made. Of the roughly 6.5 billion people in the world during that time, most were experiencing at least some benefits of global progress in some form, except for the poorest billion people in the world. We are not seeing the expected improvements in this population. They became known as the bottom billion. The billion people in the world living in extreme poverty and not experiencing the same rates of progress as the rest of the world's population. As you can see, health indicators of the bottom billion are significantly worse than global averages. So at that time, average life expectancy for the world was about 67, but average life expectancy for the bottom billion was 50, a 17-year difference. And look at the proportion of children who die before their first birthday, 4% on average globally versus 14% in the bottom billion. In the early 2000s, over 90% of the bottom billion were in low-income countries, most in the continent of Africa, which is why at that time they were often referred to as Africa Plus. Now, extreme poverty, just as an FYI, was defined by the World Bank as living on less than $1 per day in 1990, then less than $1.25 in 2005, and today it's $1.90 a day. With continued focus on the world's poorest regions, we began to see an interesting shift in the bottom billion. Today, 3/4 of them now live in middle-income countries. These changes have implications for aid to developing countries, where many funders and programs continue to focus on the lowest income countries in the world. Questions have arisen about how to address the disparities within countries, many of which have significant proportions of people living in extreme poverty, but are also growing economically and are even becoming donor countries themselves. So what does this mean for resource distribution, for health equity, and development assistance for health? And what about, for example, dental outreach and international volunteering? What does that mean for the countries that a lot of us donate our time and services to? That's discussed, by the way, in great detail in Module 5, Ethics and Sustainability. It is becoming apparent that focusing on lower-income countries alone will no longer address global poverty, particularly extreme poverty, and subsequent poor oral health outcomes. Thus, there's been a call to action to shift this focus from places to people. Additionally, the majority of the bottom billion are women and children. The particular vulnerabilities of women and children globally have been a focus of the development agenda for decades, and they are included in the Millennium Development Goals and the Sustainable Development Goals. The Sustainable Development Goals originated in September 2015, when world leaders convened at the UN headquarters once again in New York City for the UN Sustainable Development Summit. This year marked the conclusion of the MDG era, which was 2000 to 2015. Here, they adopted the 2030 Agenda for Sustainable Development. This resolution agenda stated that all countries and stakeholders will work together in collaboration toward continued progress for the eradication of poverty, with a focus on, you guessed it, people, as well as planet and prosperity. A new set of global goals emerged, designed to carry forward the Global Development Agenda as it moved from the MDG era into the Sustainable era, which is 2015 to 2030. And these are known as the Sustainable Development Goals. The global goals are discussed in more detail in Module 2. The goals and their rationale underscore the ways that gender influences health, including oral health. So let's think about some examples. So for example, access to nutrition, education, and family services can vary depending on gender. Access to resources for health promotion and prevention, diagnosis and treatment. Health-related behaviors and decision-making capacity can differ. Responses of the health system can be different for men versus women and children. Ability to take paid time off from work for specific health-related needs for an individual or for children. And another example is disparities in education level and ability to get an education. In fact, one of the strongest determinants of a child's health is their mother's education level. So let's look a bit more deeply at an example where a risk factor for poor health impacts women disproportionately: the negative effects of climate change. Take a moment to read these startling facts. Women account for a large percentage of the agricultural workforce in particular regions of the world. Changing weather patterns and more severe natural disasters due to climate change harm the agricultural industry, which in turn negatively affects women. Let's talk about an example from our work. Women and their families in Alaska's remote Arctic and subarctic tribal communities are experiencing emerging water-related challenges due to climate change, as the permafrost thaws and impacts water sources and infrastructure in the Arctic and subarctic regions. The Water Innovations for Healthy Arctic Homes conference held in September 2016 brought together Alaskan, U.S., and international engineers, health experts, climate change researchers, rural community members, and policymakers to discuss health benefits, challenges, and innovations associated with making running water and sanitation in remote tribes and communities safe, affordable, and sustainable in a time of climate change. Due to the global burden of both communicable and non-communicable diseases and their common risk factors, the conference had a special focus on interdisciplinary strategies for disease prevention and health promotion, especially improving access to water and sanitation and reducing sugar consumption. Alaskan rural communities are battling waterborne illnesses such as gastrointestinal sickness and water-washed diseases. Water-washed diseases occur when the quality and quantity of water is not adequate to maintain proper hygiene, resulting in acute infections such as bacterial skin infections, pneumonia, RSV, and severe dental caries. In fact, researchers from the region report that approximately 40% of rural Alaskan children by the age of 5 have been hospitalized for full mouth rehabilitation under sedation due to dental infections. This represents some of the worst oral health outcomes in the U.S. Water insecurity is influencing dependence on cheap sugar substrates and sugar-sweetened beverages in place of safe and palatable water. Although women can be disproportionately affected by climate change in many parts of the world, all members of the rural Arctic communities in Alaska are impacted. Let's take a deeper look at an example affecting children. Child marriage is a global problem. Poverty is a leading risk factor for child marriage. And child marriage perpetuates the cycle of poverty, particularly for girls. Other risk factors include low education rates, limited employment opportunities, reproductive burden, social isolation and depression, and family violence. Poverty relates to all of these additional factors as well. Even in high-income countries such as the United States, child marriage remains a problem. Take a moment to read these shocking statistics about child marriage right here in the US. In addition to women and children, there are other vulnerable groups that experience disparities and their negative effects disproportionately. We need to continue to collect data worldwide to identify their challenges and develop targeted solutions. The social determinants of health, such as gender and income, are important elements for disease risk. They can be equally important when considering successful treatments as well. The way a person perceives health and illness can have a significant impact on treatment processes and outcomes. So think about your answers to these questions. How would you answer these? Do you think that there are differences between your answers and your classmates' answers, for example, or maybe my answers? Any similarities? Why might that be? Okay, so for me, my mom always gave me chicken soup when I had a cold. I actually still crave chicken soup whenever I'm not feeling well. Is chicken soup evidence-based medicine grounded in science? Is that why my mom gave it to me? Likely not. It's based on my family tradition and our social and cultural practices. It's the way I grew up. So for many of us, this is the case for most of our answers to these questions. And what about Joe? Do you think Joe's answers to these questions are based on similar reasons? Probably. But historically, dentistry has focused on the biomedical approach for understanding etiology of disease and corresponding treatment. This disease model for health relies on the scientific process and evidence-based practices. Recovery from illness occurs due to a physiological understanding of how the body functions, what happens when a viral or bacterial invasion occurs, and how do we treat it. The biomedical model isolates cause and effect and treats accordingly, or prevents it from happening in the first place. So take a look at the advantages and some of the disadvantages of this approach. The advantages of the biomedical model have allowed for major improvements in health worldwide through interventions such as vaccinations, water and sanitation improvements, and antiretroviral therapy for HIV/AIDS. However, this model makes it difficult to apply complex factors like human behavior, cultural beliefs, or the social determinants of health. So let me give you an example through a story. In the 1970s, Botswana was experiencing high rates of tuberculosis. The World Health Organization sent a regional health team to Botswana to help manage the disease. The regional health team held training workshops to teach the traditional healers in the community about tuberculosis, both causes and the available treatments and medications that the health team brought to Botswana. The WHO trainers used the biomedical model for managing tuberculosis. Now, actually, though, the workshops were initially considered a failure, with the traditional healers refusing to refer people from the community to the regional health team clinics to receive the care. The traditional healers felt that the trainers were ignorant to illness in their communities and that the clinics clearly did not understand the actual causes and remedies for the disease. The traditional healers explained that the disease affects their communities differently than a European community, for example. So only they are able to adequately address the illness. The treatment sent by the WHO would be ineffective. The sociocultural model examines the personal, social, community, family, and cultural influences on the experience of illness and care beyond physiology. This model considers how people define health and pursue care based on their beliefs, customs, cultural and religious practices, social networks, and policies and governing practices. These factors impact a person's perception and experience of illness, as well as their ability to change their own behaviors. And while we won't go into it here, I encourage you to research the concept of constrained choice, where a person may know and be motivated to make a particular health decision, but is unable to due to circumstances beyond their control. These are often related to the social determinants of health. Now, back to what was going on in Botswana, the traditional healers practicing what they called Tswana medicine created individualized approaches to treating any given patient suffering from the big cough, their term for tuberculosis. This is in contrast to the regional health teams' clinics, which offered the same treatment medication to everyone. Once the regional health teams began to understand the cultural beliefs and practices in Botswana, progress was possible. They adjusted their biomedical approach and included aspects of the sociocultural model as well. And over time, the traditional healers began referring patients to the clinics, recognizing when successful outcomes are more likely through collaborative medicine, including the biomedical-based medications available at the clinics. So take a look and review the advantages and disadvantages of this model. No single model is effective in isolation, particularly in a globalizing world, with countries becoming melting pots of so many different cultures, languages, and health practices today. Optimizing the strength of both a biomedical and sociocultural model can lead to improved outcomes and better patient-provider relationships. In summary, the social determinants of disease and considering a sociocultural model of care expand the way we think about and define a susceptible tooth and the most appropriate approach for treatment. Factors like gender, socioeconomic status and poverty, culture, government and policy, physical and built environment, and many other examples can make a person and their teeth more susceptible to cavities and a multitude of other health problems. All of these complex factors have direct implications for oral disease risk, as well as finding the best methods for care and how we might define the ideal and alternative treatment options, including disease prevention for our patients and our communities. So think again back to Module 2 and all the factors that must be in place for Dr. Tooth to practice in a well-functioning health system. Add to that all the potential delays and obstacles to care that Joe faces. The patient-provider relationship and experiences of sickness and care by both patient and provider cannot be taken for granted. When a patient and provider come together and successfully manage illness as a team, or even better, prevent illness from occurring, health becomes possible for all. As dental providers, we must embrace our role in the health of our patients and our communities beyond our dental chairs. Many people will never make it that far. Moving forward after today, I challenge you to think about how to answer this question. How will you reach those who can't reach you? There are so many interesting and exciting ways to learn about the social determinants and risk factors for health. So I really want to thank you for joining me today for Module 4 of our Global Health Starter Kit. And I encourage you to continue your learning experience and explore our other modules available. Thank you so much.